where they can brush their teeth and then wash out their mouth with a chlorhexidine-based mouthwash for 1 minute. This will considerably reduce the bacterial load aerosolized in the rotary instrument spray and may exempt the dentist from having to disinfect the mucous membranes. The dentist analyzes the patient's medical questionnaire, ensuring that the information is complete by asking further questions if necessary.
Est-ce que vous êtes actuellement en bonne santé?
Oui.
Est-ce que vous avez déjà eu une anesthésie dentaire?
Oui.
Ça s'est bien passé, il n'y a pas eu de problème? D'accord. Bien, on va pouvoir y aller. Asseyez-vous.
Once the patient is in the chair, they are placed in the reclining position. The anatomy of the tooth area in the maxilla is eminently suitable for anesthesia, and para-apical buccal injection is usually sufficient. The majority of the apices are in the buccal position. The bone has a thin cortex and the superior alveolar nerves have a small caliber, so, given that all the usual protocols are followed, the conditions are suitable for achieving effective anesthesia. We will perform the anesthetic procedure via the right lateral incisor route and show the different stages in detail. The soft tissues are drawn aside and wiped with a sterilized gauze so that the area can be seen properly. The mucous membranes are swabbed with a cotton pellet impregnated with a surface anesthetic. Clinical studies evaluating injection pain suggest that this stage is justifiable in the anterior maxillary region, After checking the prepared injection syringe, the tip of the needle is positioned in the mucobuccal fold with the bevel facing the bone. Keeping the lip under tension, ensure clean and painless penetration into the mucous membrane. After injection of a few drops of the solution, the needle is pushed towards the apex. On contact with the bone, the needle must be withdrawn slightly to avoid subperiosteal injections, which are painful and will cause post-operation pain. After the first passive aspiration, the solution is injected slowly at a speed of 1 mm per minute to avoid tissue damage or serious systemic reaction, which would be produced if the product was injected intravascularly. It is strange, but true, that this point, essential for safe and effective injections, has not been taken on board by dentists, 80% of whom will inject a cartridge in less than 20 seconds. The Safety Plus syringe that we are using in this clinical case is a safety injection device which is described in a separate chapter. Anesthesia of the medial maxillary incisor can sometimes be difficult during standard procedures, but particularly tricky when performing surgical or endodontic procedures in this area. Its apex is in very close proximity with the anterior nasal spine, where the cartilage of the nasal wall is inserted by powerful ligaments which extend more or less laterally. As an injection into this fiber bundle is very painful, the injection point is usually targeted towards the apex of the lateral incisor. We use an anaject syringe for this anesthesia procedure as it gives precise control of the injection speed, a big advantage in this very sensitive area. Detailed information on the preparation and use of this type of syringe are given in a specific section on this DVD. If the anesthesia fails, the first option is to inject the mucobuccal fold on the other side of the labial frenum. Consider anesthesia of the nasopalatine nerves in the incisor canal if pain persists. To achieve this painlessly, infiltrate the medial interdental papilla on the buccal side first and then the palatine side. Use a cotton stick to compress the area. This stimulates the large diameter nerve fibers and obscures the pain perception. This strategy means you can reach the incisor papilla and access the incisor canal. The needle needs only to penetrate a centimeter, as the pressure will ensure that the solution diffuses to the nasal cavities. Amazing enough, maxillary blocks are little used, even though they are easy to perform and avoid having to give a number of injections when working on several adjacent teeth. Maxillary block anesthesia for the canine and incisor area can be obtained in the standard manner by giving a high buccal injection at the level of the canine fossa, where the anterior-superior and middle alveolar nerves cross the thin-walled bone. With the dental arches in occlusion, the corner of the lip is pulled upwards to free the mucobuccal fold and get a good view of the maxillary wall so that you can evaluate its angle and characteristics. The injection target point is at the bottom of the mucobuccal fold facing the apex of the first premolar behind the canine pillar. The needle goes in vertically and parallel to the bone wall at an average depth of 15 to 20 millimeters for a maxilla averaging 4 to 5 centimeters in height. Aspirate frequently as the facial vein and branches of the infraorbital artery cross this area. The frequently observed phenomenon of skin whitening seen after injection is explained by the crossness of these vessels. In some cases, analgesia of the two premolars can also be obtained by this technique. This is the gold standard for the molar region, whether you want anesthesia for just one tooth or a complete molar block, as it avoids the cortical bone of the maxillar zygomatic process. Ask the patient to slightly open their mouth and then move the lower jaw on the side to be injected so that the area can be seen clearly and the mucobuccal fold accessed. Perforate the mucous membrane facing the mesial buccal root of the second molar. The syringe is oriented at an oblique angle of 45 degrees to the plane of occlusion and 45 degrees to the bone surface plane. This will avoid damaging the extraosseous branch of the posterior superior alveolar artery located under the periosteum. Penetration depth of the needle must relate to the height of the maxilla, which is, on average, 15 millimeters. You must aspirate after delivery of each quarter of the cartridge in this region. As the middle superior alveolar nerve supplies the mesial buccal root of the first molar in about 25% of cases, a further anesthetic procedure in front of the zygomatic process is sometimes needed. Similarly, if root divergence has meant that the sinus is located between the buccal and palatine roots, an additional palatine injection facing the apex will be needed The solution will diffuse through the vascular channels of the hard palate. If anesthesia of the mucous membranes of the palate is required, the innervation of the area means that two different sites must be injected. To anesthetize the molar and premolar area, the needle is inserted facing the second molar in front of the greater palatine foramen. At this level, the thickness of the underlying connective tissue means you can inject 0.2 to 0.3 mm painlessly without pressure. If you also require hemostasis, it will be easy to complete the process afterwards on the neck of the teeth as far as the first premolar. The needle prick and the injection are always painful in the incisor and canine area, even if you use a surface anesthetic and apply pressure with a cotton stick. Block anesthesia for the canine and incisor area via the palatine route has been popular in recent years due to the development of electronic injection equipment. The main advantage of this technique is that you do not have to give the labio-nasal juggle anesthesia, which is standard for all the buccal techniques. It is recommended if you are to determine the length of the incisional edge of anterior teeth in relation to the smile line, as it does not produce dropping of the lip. This technique can be used with standard injection equipment or with automatic electronic injectors, such as Anaject, which can be programmed to control the speed of injection. With this approach, the point of penetration of the needle is located halfway between the median palatine suture and the neck of the premolars. Between 0.9 and 1.8 mm of the anesthetic solution is injected slowly, diffusing through the maxillary bone via the numerous orifices of the palatine vessels. This technique has some advantages. However, it also has drawbacks as the anesthetic onset is slow and there is a variable success rate of 35 to 58% depending on the tooth involved. We do not consider that it is a real alternative to the buccal route as its field of application is too narrow. Para-apical buccal anesthesia of the lower incisors and canines is usually effective as long as the tip of the needle is positioned correctly at the apex. The procedure may not be successful if the needle penetrates too deeply as the thickness of the cortical bone is greater and obstructs the diffusion of the anesthetic solution. Some unsuccessful procedures could also be related to possible nerve substitutions. If after injecting half of the cartridge into the mucobuccal fold, the right medial incisor is not anesthetized, you will have to inject the mucobuccal fold on the other side of the labial frenum, as the incisor nerve sometimes crosses the median line. If the anesthetic has still not worked, there may be a mylo-iogen nerve substitution and an additional lingual injection on both sides of the frenum should block this and the anterior belly of the digastric, which supplies the incisor plexus in 50% of cases. Finally, if the pain still persists, you should consider anesthetizing the two mental nerves, as some of these nerve fibers may contribute to the incisor plexus. This theoretical model aims to explain the complexity of the nerve supply in the chin area. In cases where rapid treatment is required, you could dispense with this technique and use intraosseous anesthesia instead. However, it is a suitable technique in surgical situations if a bone chin graft is required or when excising a cyst in the chin region. There are few indications for anesthesia of the mental foramen, but it may be the best technique to use when dealing with the first premolar. It is actually an intraosseous anesthesia technique which uses a natural orifice as the diffusion route. As the position of the foramen can vary considerably, a retroalveolar X-ray remains the best process to pinpoint its location. It is not a recommended technique, as if the needle penetrates the mental orifice, you risk damaging the neurovascular bundle. The direction of approach should be from the back towards the front, and a third of the cartridge should be injected behind the mental foramen. However, although this atraumatic approach is as effective for first premolar anesthesia as injecting the foramen, it has been demonstrated to be less effective for the second premolar and the canine. You should then massage the area in the same direction for a minute or two, as this will help spread the solution to the trabecular bone.